Wonderful. Welcome, everyone, and thank you for calling in to today's Suicide Prevention Cyber Seminar. This event is presented by the VA Suicide Prevention Research Impact Network, or SPRINT, where we highlight ongoing and high-impact suicide prevention research in veterans. I'm Mark Gilgen, and I'm a psychologist and research career scientist at the Ann Arbor VA Medical Center. And today, we're lucky to be able to hear from one of the real leaders in VA suicide prevention research, Dr. Marianne Goodman, who will be talking about her work on safety planning and lethal means safety. A little background on Dr. Goodman. She is a professor in the Icahn School of Medicine at Mount Sinai in New York City and a full-time VA clinical research physician at the James J. Peters VA Medical Center in the Bronx, New York City. She is currently the Associate Director of the VISN-2 MIREC and the Director of the James J. Peters Suicide Research Program, as well as co-director of the Transitioning Veteran and Service Member Suicide Prevention Program. Her clinical expertise is in the treatment of dysregulated emotion, including anger, aggression, and suicidal thoughts and behaviors in veterans. Her funded research is in the novel treatment development and biomarkers for suicide risk, and she previously served as the president of the North American Society for the Study of Personality Disorders. With that background, I'm pleased to hand it over to Dr. Goodman.
Well, thank you so much, Mark and the Sprint, for inviting me to speak this morning. I'm really excited to share my work in this area over the past decade. In terms of my disclosures, I want to thank the VA RR&D and CSR&D for funding this research, along with the New York Health Foundation and the resources of the VISN-2 MIREC. I have no conflicts of interest to report, and just to mention that the views or opinions expressed in this talk do not represent those of the Department of Veteran Affairs or the US government. So I want to start out with the 10,000-foot overview on evidence-based treatment approaches that are suicide specific. And you can see on this list, it includes DBT, CBT for suicide prevention, and the Collaborative Assessment and Management of Suicidality, or CAMS for short. But it also includes some briefer evidence-based treatments, including safety planning and counseling about lethal means. And these last two will be the topic of what I'm going to speak about today in this cyber seminar. So you all know what suicide safety planning is. It's developed by Barbara Stanley and Greg Brown. It's a best practice and mandated across the VA system for high-risk veterans and upon discharge from inpatient settings. So what do we know about suicide safety planning? Well, lucky for us, a comprehensive PRISMA scoping review was just published in April 21 by Ferguson et al. It included 20 quantitative papers and 6 qualitative papers. They did screen 565 articles to get to those 26. Interestingly, half of them were standalone safety planning, and the other half included another intervention in addition to the safety planning. 20 of them were in-person format, and the other 6 included telephone or telehealth. 14 of the 26 had suicide-specific outcomes, and 3 of them included groups, and that'll be important for this cyber seminar. Importantly, all the outcomes for these 26 studies did show improvements in the suicide spectrum across ideation and behavior, depression and hopelessness, as well as very good acceptability and feasibility. So I've spent the last 8 years primarily focused on building new adaptations to safety planning. And I'll be talking about these through the course of this talk, including group settings, telehealth delivery, and interventions, safety planning interventions that involve family. You can see the different colored arrows. Those colors will continue to propagate throughout the talk. And I will talk about PRISMA scoping reviews first, and then introduce each of the projects. So starting out with group settings, our research team has been particularly interested in group formats, especially for veterans who prefer peer interventions. So this is a PRISMA scoping review that our group has embarked on. And we wanted to ask the question, what research exists on group interventions that have specific suicide outcomes? What do we know about the efficacy of these interventions? And then also, do any of these interventions use suicide safety planning? Now, it's important that we restricted this review to modalities that are only group. So if the intervention included some individual work in addition to the group, it didn't qualify. So something like DBT, where there is individual therapy in addition. We also required that suicide be openly discussed. And again, in DBT, that is, their group intervention does not encourage discussion about suicide, and that it needed to be part of a research trial. So out of 1,369 articles that were screened, we ended up with 10 that we included in the review. 8 of them did include skills training. 4 of them, with some overlap, did also include reasons for living. 5 of them had aspects of safety planning in this group. And they did meet weekly, anywhere from 8 to 20 sessions. Unfortunately, the rigor of these trials, only 7 of them were open label, so 3 of them were not. But importantly, all 10 highlighted improvements in suicide-related outcomes. So now I'm going to talk to you about Project Lifeforce. This is the group intervention that we've developed. And again, the idea here is that we want to keep high-risk veterans alive through a group safety planning intervention. My collaborators on this are Greg Brown and Barbara Stanley, again, the creators of the VA Suicide Safety Plan, and Michael Thace, who runs our Philadelphia VA site. So the origins of this project, I was a DBT therapist for about 13 years, running a DBT program in the VA. And this was a study that was funded by the Department of Defense to look at the relationship of DBT treating suicidal veterans irrespective of diagnosis. And unfortunately, this was a negative study. Both groups improved in all the outcome measures, except that individuals in the DBT arm had twice as many visits as the TAU arm. So this was a little bit of a crisis for me professionally, since I had banked on really continuing my pathway in DBT. And so I really came to a crossroads what I was going to do next. Around the same time, I had developed a caseload of many of the high-risk suicidal veterans in our hospital. And one of my patients actually had had a very difficult day and was walking on one of the bridges in New York, contemplating jumping. And he took his hand and hit it across his chest and said, "I just can't take it anymore." And when he hit his hand against his chest, he realized that there was something in his front pocket. It was a button-up shirt with a pocket in the front. He unbuttoned the pocket, and lo and behold, there was a piece of paper. He took it out. It happened to be a safety plan. It was the shirt he wore upon discharge from the inpatient unit where he had been discharged a couple days previously, had taken the safety plan and stuffed it in the pocket and completely forgotten about it. Coincidentally, was wearing the same shirt a couple days later. Unfolded the piece of paper, looked at it, and saw that, oh my gosh, this is crazy. I have 4 children. What am I doing? Took his phone out, started looking at pictures of his children, walked off the bridge and called me. But this incident was a particularly watershed moment for me because it made me realize that if we can make suicide safety plans relevant, personalized, and accessible, that we can save veteran lives. And so this also became the answer for me of what my next path was going to be. And so what I ended up doing was combining the best out of DBT, cherry picking out what I thought was most important and applying it to suicide safety planning. But before I could do that, I needed to learn a little bit more about suicide safety plans. And so we conducted a study, this is with Debbie Kamen, a colleague of mine in the Vision 2 MIRIC, where we interviewed 20 veterans upon the creation of a safety plan, and then we interviewed them 1 month later. And what we found was there was a wide range of use. Many of the veterans said a month later, "What safety plan?" While others were using that plan several times daily. We did learn that the importance of collaborating with a clinician on these safety plans really made for increased use, and we identified both obstacles and facilitators. The obstacles included a lack of a social network. Patients felt too depressed and too much of a burden to carry out the safety plan contents alone. And those that actually had shared the plans with significant others, including family or spouses, or their therapist, really found the plan much more helpful. as well as actually having that plan readily accessible. Patients were putting them on their refrigerator, in their car, at their work, but anywhere where that safety plan could be used and when needed. And also, the more individualized the plan, the more helpful it was. So this is Project Lifeforce. It basically uses these DBT skills, to distress tolerance and emotional regulation, but it applies them to particular steps of the safety plan. It introduces the use of a mobile suicide safety plan app, so that that app will have their safety plan, so they always have it near them. We actually help patients identify those that they can call for help. Veterans have a very hard time asking for help, and so one of the things that we do in this group is we practice role-playing and asking for help. Again, the idea is to develop detailed, personalized, and meaningful suicide safety plans. And for me, the secret juice is that it's delivered in a group context for offering peer support. What I didn't appreciate at the time when I developed this treatment was that veterans are very used to being in life and death situations with each other. And so basically little units formed, and patients were coming to the intervention. They may have been too depressed for themselves, but they were coming to make sure that the other people in the group were okay. So again, Project Lifeforce, it's a group. It teaches skills and uses psychoeducation to develop a safety plan and make that safety plan accessible. It is manualized. I think at this point, the manual is over 80 pages. And it's done in 10 sessions, and patients come in when they need to. So when they're coming off the inpatient unit, or if they've been identified with an exacerbation by their clinician or on the high-risk list, they come in as soon as possible, and they stay for 10 sessions. They do not have to start at the beginning. It's meant to facilitate ease of entry, as well as that mandated documentation for high-risk individuals. So what does this treatment look like? The first session is all about identifying crisis prevention services. We have the suicide prevention coordinator come in and speak to the group. We actually have people practice calling the crisis line and send them out for homework to make that call when they're not distressed, so they can make it when they are distressed. The second session has to do with warning signs, and we teach emotion recognition skills and really describe the cascade that gets somebody to be suicidal. The third session is about the second step in the safety plan, internal coping strategies, and here we teach distress tolerance skills. The fourth and fifth session have a lot to do with people who you can ask for help, either for distraction or to actually put these people on the safety plan. And here we spend a lot of time talking about the pros and cons of identifying who to put on the plan, and then practicing how to actually ask them to be on the plan. These tend to be some of the most challenging sessions to run, but actually sometimes the most rewarding. The sixth session has to do with the clinician and the team, and making sure that clinical team, that the relationship is as strong as possible. We talk about any obstacles that might be there. We talk about medication compliance, and we actually send these patients out for homework to have their primary clinicians sign off on the safety plan as it has been developed. And then the session 7 is the last step of the safety plan, which is making the environment safe, all about means restriction and lethal means safety. In addition, we've added a couple additional sessions outside of the safety plan. One is we download the virtual hope box, and we go over all the other apps that are available within the VA. We particularly like the virtual hope box because patients can take pictures of their safety plan and actually upload those onto the virtual hope box. And there also are some nice distress tolerance and meditation tapes that they can listen to as well. We have a session looking at physical health management and the relationship between pain and sleep, diet and exercise, and keeping as healthy as a mind as possible. My favorite session is the 9th session, which is really about identifying reasons for living. We talk about the very small things in life that bring joy. The veterans actually compile a list during that session, and then they staple that on the back of their safety plan. And then the 10th session is basically a recap and review where they go over the entire safety plan in a group together, sharing what the changes they've made together and what's worked and what's been particularly helpful. So we were lucky to be funded by a SPIRE grant from RR&D, where we had 45 veterans come through our pilot, where we developed and really finalized the manual, had very nice satisfaction and feasibility. Well, that less than 20% didn't finish the treatment, and every single patient that participated did update their safety plan and use it in a more frequent basis. We also had some very nice preliminary outcome measures, suicidal symptoms, depression, and hopelessness, very nice decrements in this open label trial. We did receive some nice press about the Project Lifeforce. We were featured in the VA Research Currents, but the honor that I'm most proud about is one of the patients who felt that the PLF intervention saved his life, called up his local congressman to say that he felt the VA doctors were not getting enough recognition. The local congressman contacted somebody at the Capitol building, and on June 17th, 2018, a flag was flown over the US Capitol and dedicated to the Project Lifeforce intervention. The flag was then sent back to the patient, and he actually presented the flag to me in this wonderful ceremony, and that flag now sits in my office. To me, it's the highest honor that I could receive. But I think it does speak to the power of this intervention. We now have been funded by CSR&D Merit in March of 2018. 3 sites, Bronx and Philadelphia, VA are the recruitment sites, and Columbia University is our training and adherence site. Our goal is to recruit 265 patients into this trial, where we randomize to either the group, which is Project Lifeforce, or the individual suicide safety planning. And this is the Contemporary Clinical Trials Communications, our protocol paper. What we're really happy about this project is that our primary outcome is suicidal behavior. We're 3.5 years into the trial, and so far we've recruited 185 patients into the trial. And what I want to tell you about now is of the 140 PLF group sessions that have been run between both sites, of these, over 60, so almost half, were virtual groups. With COVID-19, we were able to quickly pivot to a telehealth version of this high-risk suicide safety group, and I'll be telling that to you shortly. We also were able to move all of our research methods so that we can conduct them remotely. We now consent remotely, and all our assessments don't require in-person people. Okay, so let me now shift a little bit to the telehealth delivery of the suicide safety planning. And even prior to the COVID-19 pandemic, there were several barriers that made in-person care difficult, and these included inflexible work schedules, travel costs, and certainly at our hospital, parking is a nightmare, health issues, caregiving responsibilities, and physical disabilities. Now, these barriers are especially prevalent, not just in Bronx patients in an urban setting, but particularly in rural areas where individuals have elevated risk of suicide, but also have the least access to care. So again, our research team conducted a telehealth and suicide-specific care PRISMA scoping review. And this time we asked the question, what research exists on full telehealth clinical interventions with suicide-specific outcomes? And again, we conducted this during the pandemic, so since we were unable to see patients in person, we really wanted to know what was out there that was fully telehealth. And what do we know about the efficacy of these interventions? And do any of these interventions that are using telehealth use safety planning? So we were able to identify 212 full text articles and ended up with 9 that met our inclusion criteria. And it's interesting, these evidence-based treatments that I talked about earlier in the cyber seminar, delivered via telehealth, do not have empirical support yet. So these 9 studies that came up, none of them were evidence-based treatments at this point. 7 out of the 9 telehealth studies were follow-up interventions that were targeting patients who were discharged from the emergency room, and they were mostly telephone, and they ranged from 5 minutes to 40 minutes with an average of about 22 minutes. Now, I do want to give the caveat that because this was really conducted, this PRISMA review, during the pandemic, it doesn't really capture the conversion that's been prompted by the pandemic. So future scoping reviews will obviously have more. This really gives you the state of the field prior to the pandemic. Continuing with the results, 2 of the studies incorporated lethal means counseling, and 1 of the studies did involve suicide safety planning. Okay, so I'm going to say a little bit more about our Project Lifeforce telehealth. So now we're talking about PLFT, and I want to really just acknowledge the work of Sherry Jager-Hyman, who is my co-therapist in the PLF intervention, Sapana Patel, who's going to be helping us with a qualitative study, Rebecca Rasaborski and Sarah Landes, who will be helping us with an economic study of the difference between telehealth and in-person group treatments for suicide. So we began teleworking in March 2020. Our first telehealth group was March 18th, 2020. We were very able to quickly pivot, as I mentioned. And at this point, we have over 60 of these telehealth group PLF sessions to date. We've learned a lot during the past year of doing these groups via telehealth. One of the most important things is that we now have a communications coordinator. So one of our RAs is specifically tasked with making sure that everybody has the link to these group sessions, helps them get onto the group session either by telephone or patches them in. If they fall off for some reason, she's on the phone calling them to find out, but it does really require the resources of somebody to help really with this coordination piece. Now, we tried multiple platforms. We started out with VVC. We quickly had to disband that because so many of our veterans, and I'd be curious to hear if this is the case elsewhere across the country, but so many of them do not have either a computer or internet access that's reliable, and they're calling in by telephone. So I'd say anywhere between 1/2 to 2/3 of our group members are calling in by the phone. And VVC did not allow phone and video at the same time, where WebEx does. So this is the platform that we've been using with some success, and it's been very helpful. We show the manual on the share screen, so the patients are also emailed them and mailed the manuals, but we can also show them on the screen, and we also pull up individual safety plans to make the edits to the safety plan on our share screen. As I mentioned, we've learned a lot about how to address the barriers, particularly issues with connectivity, but also noise and privacy. We have patients who have dialed in while on the subway, on a bus, driving their car, in crowded rooms with other people. And so we've really had to stress over and over again the importance of kind of muting yourself and also making sure that the room is private without other individuals, especially for group, because you want to maintain the privacy of the other group members as well. The assessment and management of high-risk behavior, this is still a work in progress. We used to, with in-person groups, deliver a piece of paper, which was our CSSRS screening, with several questions so we could quickly assess whether the suicide risk of anybody at the beginning of the group. And how to do this over a virtual format has become quite a challenge because we tried actually texting people, emailing people, having them go into side rooms, stopping the group in the beginning to ask these questions, and without it taking, 20, 30 minutes of the group. It's still a work in progress. So this might be, if anyone in the audience has any suggestions of what they might have been doing, or if they are doing something similar, we'd love to hear. As it stands right now, we're hoping people can, they know what the 4 questions are, and we're hoping that they can either text us or tell us upon entering the group each session, but we'd love to, if there are any other ideas out there. We're also working with the VA to obtain tablets for group members who don't have smartphones. But I do want to stress, despite all these obstacles, we have been able to combine the group across the Philadelphia and New York site, which is now making for robust numbers of veterans in the group. And the really wonderful thing is it now allows veterans who are traveling or who had to relocate because of the pandemic, they could still stay part of this group. And the other thing that's been really very helpful for us is it's allowing us to expand our recruitment for this study beyond the initial Philadelphia and Bronx sites. We're trying to bring on Northport, and the beautiful thing is they will also be joining the same group. So it really does allow for a much wider net for recruitment, and this is something to be thinking about for future studies as well. So we do have the data from the first 9 telehealth PLF completers. And this is acceptability, appropriateness, and feasibility, which is comprised of 4 items on a scale from 1 to 5. And the total can be anywhere from 4 to 20. And you can see, based on these first initial completers, that the scores are pretty good for feasibility and appropriateness. So we're continuing to gather this data. We absolutely want to learn more. Initial people started out with half in-person and half telehealth. Obviously now the veterans who are coming through are 100% telehealth, but we really want to understand what the veterans' perspective is as we move to these telehealth directions. This is a very busy slide, but it's really just to tell you that we're now embarking on qualitative interviews for PLF group participants who underwent the telehealth version. And we will be getting a lot of information that we would be to be sharing. We're making a big effort to capture those people who didn't like the format and to try to understand ways to move this forward. I also mentioned that we received a supplement to also do an economic analysis of the in-person versus the telehealth, and so hopefully we'll have those results in the next 6 months or so. Okay, moving now to involving family. There's a lot of rationale to include family. We know that family systems on suicide prevention is a largely unstudied phenomenon. We know that families, in addition to being a risk factor for suicide, can also be protective through cohesion, connection, and positive emotional support. And a review of clinical interventions done by Spirito back in 20 years ago or so did conclude that family is a promising target for suicide interventions. Okay, so moving now to our PRISMA scoping review, we asked the question, what research currently exists for family treatments for individuals at risk for suicide? What is the efficacy of these interventions? And again, do any of these family interventions involve safety planning? And I just want to specify that when we talked about family treatments, we were only considering treatments where both the suicidal individual and the family member came together to see the treatment provider. So treatments where the family is just seeing the person separately from the suicidal individual were not included in this review. So out of the 180 articles reviewed, we were able to identify 10 interventions that involve families with suicide-specific care. 40% of these employed some type of cognitive behavioral therapy. Another 20% used attachment-based family therapy. 20% used family-based crisis intervention, and the other 20% were distinct from one another. Interestingly, 90%, so almost all of the studies in family pertain to treating children and adolescents at risk for suicide, and only one targeted adults across the lifespan. So So the current state of the field is there are no sibling-specific interventions. There's no family-based treatment for geriatric populations. And most of the family members that were targeted in these treatments obviously were parents or guardians with their children and adolescents. So clearly a very large gap if you're an adult researcher wanting to do family work in this area. So where does the safety plan fit in? Although safety planning was integrated into some of the studies, none of them exclusively focused on the safety plan or the crisis response plan, and none of the studies specifically reviewed how family members could be involved in restricting access to lethal means, two factors that our group is particularly enamored with. Okay, so this intervention, it's called Safe Actions for Families to Encourage Recovery, or SAFER. I'll be referring to the SAFER intervention for the rest of this talk. And this is a pilot RCT, which we were funded by our R&D for. Really want to thank Deb Krasta, who really was instrumental in the data analysis of this trial, Shirley Glynn and Barbara Stanley, who are consultants, and Deborah Perlich, who helped me design the therapy as well as the initial grant submission. So in order to develop this treatment, we conducted some qualitative interviews, 26 veterans and 19 family members, and we wanted to understand their perspectives on, how do you involve family in veteran suicide prevention efforts? What's the family know? What do they need? And in interviewing the veterans, 4 themes really kind of emerged. One is a deep sense of isolation. I have a big family, but it's like I have no one. Shame, deep down, a part of it is shame, and really one of the big obstacles for being able to disclose. A sense of burdensomeness. I felt like a burden. I wanted to reach out, but I didn't. And a deep sense of mistrust that family members will just flip out or won't understand if they disclose some of their suicidal symptoms. And likewise, family themes emerged. Families really identified an inability to stop their loved ones from hurting themselves. For instance, it's hard for me to find out things that's going on with him. He keeps to himself a lot. They were very worried that if they asked questions that they would somehow trigger suicidal urges. I just never know how he'll react. They felt unsupported and very overwhelmed. I just don't know what to do. So kind of in summary, veterans felt alone and afraid to reach out to family members, and family members likewise didn't know how to support or react to their veterans' suicidal symptoms. And these themes formed the basis for our SAFER intervention. So basically what we decided to do was to have a protocol that encourages the discussion about suicidal symptoms and how to cope with them, and doing this through the development of a veteran and a complementary family member safety plan, and I'll show you that in the next slide. We used psychoeducation. We wanted to facilitate disclosure and really emphasize communication skills. So basically, patients and their loved ones come in separately for a joining session where we go over what the expectations are, kind of review the goals of the treatment, identify any obstacles, and really do some motivational interviewing so we're all on the same page. And then there are 4 sessions where the family member and the veteran meet together to build this complementary veteran and supportive partner safety plan. And this is what it looks like. On one side is your typical veteran plan, the steps that we've all talked about, and on the other side is in blue is the family member safety plan. So just to give you an example, step 1, the veteran would talk about his warning signs, and the family member's step 1 is recognizing the warning signs in their loved one. So if isolation and turning your phone off are some of the warning signs, we are teaching the family member what to look for in the veteran's warning signs. Similarly, step 2 is using internal coping strategies. And here, step 2 for the family member is coaching the veteran on what coping strategies to be used. So they're constructed together, they're complementary, and they're really meant to facilitate the family member helping the veteran use that safety plan to make it as effective as possible. So the study included 39 veteran and support dyads. We spent a lot of time trying to figure out what the correct word would be. They're not all family members. So just to break it down, 14 of them were romantic partners or spouses. 13 of them were other family members, so either a parent or a child over 18, but also 12 of them were very close friends. So again, it's this idea of a supportive partner. The veterans themselves, these were moderate risk veterans, veterans who'd had ideation within the last month or a lifetime suicide attempt. Okay, and the design of the study was there were assessments done at baseline, post-treatment, and 3-month follow-up, and individuals were randomized either to the safer intervention, which involved the family, or individual safety planning, which is what is current treatment as usual, where the veteran would meet with one of our research staff and construct an individual safety plan. Now, the hypotheses were we believed that the safer intervention would decrease ideation in the safer arm, that mutual coping, so both suicide coping and coping support for the family members would be improved in the safer arm, but that also those interpersonal cognitions, what I was referring to before that we came up in our qualitative study, the feeling like a burden, feeling isolated, caregivers feeling overwhelmed and burdened, we wanted to see whether the safer intervention would target these interpersonal cognitions greater than the individual safety planning. So just to kind of go over the results, here we're comparing SAFER, which includes the family member, compared again to safety planning individually, which is what we're currently doing. And the severity scale of the CSSRS, 4 and 5 include some level of intent, greater than 3 denotes some level of planning, and 1 to 2 are lower level ideation. And what you can see here is that veterans in the safer arm are showing decreases in the severity of their ideation, not zero ideation, but decreases. And this we thought was very, very exciting. Moving now to this suicide-related coping, and here you can see what the veterans are doing to cope with their suicidal crises. Really is pretty much the same. In the SAFER, there are some slight improvements in the later assessment waves, but it's not a significant increase. However, when we look at the partners, here we can see some action. So again, in the SAFER arm, there's increased confidence in coping. It slightly increases, but again, it's not significant. But what you can see in the individual safety plan where the family members are not included, that family members with each time check-in are less confident in their ability to help their loved ones. Unfortunately, we didn't see any changes in the interpersonal cognitions, which was disappointing, but actually we did feel that the results were encouraging. So kind of in summary, what we're seeing is that keeping and bringing the family to the table, we actually do see decreases in veteran suicidal ideation. You don't need real shifts in interpersonal cognitions for change. So again, just to kind of state that again, simply having family members come to the table to help their veterans and giving them skills and ideas what to do may be enough to move the needle for helping veteran suicide prevention. Now, I just want to kind of make some caveats. The arms weren't matched for treatment dosage. The SAFER was 4 sessions with the individual, whereas the individual safety planning was 1 session. Again, these were moderate suicide risk veterans. We don't know what this intervention is like for more acute risk. We did have attrition challenges. It was a small N study, really some obstacles in recruiting family members to want to be partaking in this treatment. And we weren't able to examine moderators, the gender, the suicide status of the veteran, nor the status of the partners. We are interested in seeing what a telehealth delivery of this intervention might look like, and those will be our future next steps. I just want to now move to another family related project, just to kind of keep in this theme of families. We know that the VA has been very involved in lethal means safety initiatives, and these have included free firearm cable locks and free firearm safe storage kits, and as well as the Together with Veterans community intervention, which is going to be rolled out as part of Suicide Prevention 2.0 efforts. And if you think back of that very first slide where I showed you about evidence-based practices, one of them was COM, and COM stands for Counseling on Access to Lethal Means. And what we do know is that COM training, so teaching providers about how to counsel others on limiting access to lethal means is very helpful. COM training research has been conducted upon mental health providers, emergency department personnel, case managers working in geriatric care settings, and residence hall administrators in college. So there's a gaining evidence base about the utility of doing these kinds of interventions. However, there haven't been any COM interventions that are specifically targeted to family members. And so we are pretty excited about that. So in collaboration with the New York State Governor's Challenge team, which I'm a part of, we are working with Stephanie Gamble and Rob Lane on that team, as well as some people from the New York State Suicide Prevention Office, Gara Lloyd Lester, but also Elaine Frank and Kathy Barber. They're the creators of the COM training, and they're helping us adapt this training for family members. And we're now funded by the New York Health Foundation to move this project forward. And basically, in order to best understand what family members need, we conducted 23 interviews. These were done in 3 different groups. One group was family members of veterans who unfortunately died by suicide with a firearm. Another group was family members of veterans where the veteran attempted suicide using a firearm. And the third group were family members who lived with a veteran who had firearms in their homes. And we wanted to learn, what do they need, what do they know? And it's clear that they need a lot. We were really trying to find family members who have successfully navigated safe storage with discussions with family members, and they're few and far between. So we also learned that they don't want a training in the sense of the training that we go through for all our webinar and interactive trainings. Instead, they want to hear personalized stories of other family members who have had to grapple with similar kinds of problems and found workable solutions. So that's what we're doing. We are writing scripts for 5 different scenarios involving family members. We have our design team, we've got the videographer hired, and we are looking to spend the summer developing this interactive website. I just want to let people know that this website, while it's going to be New York based and have some of the storage laws around New York, we are building this interactive site so that it can be easily tweaked for other states. So if there are people who are on different Governor's Challenge teams and on the subgroup working on lethal means, please reach out to us. This is going to be a resource that we want to be available nationwide. Okay, so just to recap, really talked about various different directions, where suicide safety planning is, group adaptations, telehealth adaptations, and adaptations that involving family. I could not do this work without the help of so many talented and dedicated people. I just want to thank the individuals I work with at the Bronx VA and Division II MIREC, several of my RAs and postdocs. I want to point out Stephanie Gamble and Deb Krasta at the Center of Excellence, and the collaborating sites for the Project Life Force Merit, Maureen Monahan, Michelle Gordon, and Carolyn Meyer. And please, I also mentioned all the co-investigators earlier in the talk. So just, it's a big team, it takes a village, and happy to be part of this village. Stop there and answer questions.
Fantastic. Thank you so much, Marianne. We do have several pending questions here, so I'm just going to start working through those. The first question we have here, what distress tolerance skills do you teach in session 3?
So as I mentioned, I spent many years doing DBT, distress tolerance. So we really kind of picked up many of those. So we teach literally distraction and self-soothing and crisis management. So we actually have the patients tell us what they do for distraction. Tell us, and we literally give examples and we share them within the group, and then we actually send them out to actually try different skills that they've learned about from the others in the group. The self-soothing is actually hard for a lot of veterans. Self-soothing often has been done through alcohol and drugs, and we try to really talk about healthy self-soothing, so meditation, relaxation, and here we'll bring in some of the resources that are available on some of the mobile apps as well.
Great, thank you. The next question here. As a member of my state's governor's project, we've been discussing that safety planning is not necessarily done with fidelity from clinician to clinician.
Yeah.
Can you talk to how you address efficacy and fidelity of safety planning? Is there a specific training that VA or SMVF clinicians should complete in order to ensure that they are creating quality safety plans with their clients? Perhaps it is CAMS.
So whoever asked that question, you're right on target. I think the quality of the safety plans makes a tremendous difference, and part of our research project is we are grading the safety plans, because I do think sometimes they're filled out very quickly. Sometimes you've had clinicians that spend 20-30 minutes on them. This group, they spend close to 9.5 hours building a safety plan. So obviously the more you put into it, the more you're going to get out. So really the quality does make a difference, and Greg Brown is helping us with the grading. There are publications on, I think it's Gamara has one, but Greg also has another one for the actual, how do we go through and actually look at them and score how each step is filled out. There are trainings. I know that as a VA clinician, we do have to attend safety planning online trainings, and there is that available as well. I do think that the more we, when we talk to different providers about safety planning, they just felt it was just another requirement that they had to do to check the box. And I think if we can really instill in providers that this can be a life-saving, it's really valuable. It's evidence-based, and have the patients speak about the power of safety planning. I think clinicians will be more motivated to do justice to the intervention. I will say what makes the group intervention with safety planning so helpful is that often patients don't have a lot of skills, so they don't know what's coping strategies that they want to employ when they're feeling overwhelmed. And so by teaching them those skills that they can then use on the safety plan, I think that the marriage of sort of DBT, emotion regulation skills, distress tolerance skills with safety planning is sort of where the money is.
Great, thank you. The next question here, is the PLF manual available for ordering? This would be a very helpful resource to incorporate at the domiciliary.
So thank you for that question. So when I've presented the Project Life Force in previous conferences, normally people would come up to me afterwards and ask me for the manual, because I think it really speaks to clinicians. Because it's manualized, it's fun to run, and the patients do a lot of the work. So the clinician just kind of has to steer the direction of things. It's a little bit more challenging with the telehealth because you've got to monitor the different facets. But because I have to prove its efficacy, which is why we're involved in this CSR&D merit right now, once I can prove that it's more effective than treatment as usual, then I think we can move to the dissemination and implementation phase. But in order to kind of get ready for that phase, I am having, if there are individual sites that want to sort of see what this is like so we can kind of learn a little bit ahead of time. It's one thing to come out, it's one thing if it comes out of my hospital, but it's something different when it's not in the creator's environment. So, we are looking for partners to kind of team up with. So please, here's my email, please reach out to me. Maybe we can think about this, or I've had different people from inpatient units say they want to adapt this for, for patients who are hospitalized. I'd love to kind of talk and see where other people think this could go. Opening for future collaborations.
Great, thank you. Next question here. Since Barbara Stanley participated in this research project, do you think that creating safety plans with family or significant support person will become the standard for individuals who are not veterans? Is this going to become a best practice?
So, we were very excited. It was a pilot study, so it's a small and, while it was randomized clinical trial, it's still 39, so it's really considered on the small side. I think what I didn't tell you is it took us 350 people that we had to approach in order to get the 39 veterans to participate. This is a very hard treatment. Veterans don't want to include their family members don't want to be bothered and burdened anymore. I think that family interventions are an important part of the arsenal. I just don't know that it's going to be for everybody. Most of the veterans, what would happen is we would approach prospective veterans for both this study, the family study, and the Project Life Force study, and they all wanted the Project Life Force. They much prefer talking to other veterans than talking to their family. Veterans understand me, my family doesn't. So, in my mind, I'm sort of thinking of this as a sequence. Maybe people do a sort of a peer intervention, they get that safety plan ready to go, and then they share it with a family member once it's sort of robust and used. The sessions where we talk about involving family in the PLF, they're really spirited discussions. Lots of people feel their families just don't understand them. So I think we need a little bit more work. That this was the SAFER was like the first entree into family treatments. I think we still need much more refinement. I think 4 sessions still might be too long. Maybe we could thin it down. We have to really look at, is the family member one of the triggers for suicidal urges and impulses, in which case you might need a different intervention. So I think it's the beginning. I think we've opened Pandora's box about the importance of family, but I still think there's a lot more work to be done till we call it the be-all to end-all.
Great, thank you. The next question here. I like how you start your project with Prisma scoping review. Can you tell us more about how that works?
So Sarah Sullivan, who is my lab manager, loves scoping reviews, and you can see her name is attached to every one of these. So basically, she has formed a relationship with the librarian at Icahn School of Mount Sinai. And basically, the librarians know how to do this. You meet with the librarian, you come up with the search terms for the articles that you're hoping to find, and you end up with like thousands upon thousands. So some of these are 4,000, 5,000, and you actually have to go through all the abstracts to see if they're relevant. So if you put in family and suicide, it could be have nothing to do with what we're looking for, and so it requires 2 people to review all the various abstracts. So a lot of our research staff has been involved in this. We get student volunteers. It's a wonderful way to involve others in this work. They look through all the different abstracts and they identify the ones that they think are pertinent, and they both people have to agree. And if one says yes and one says no, it has to go to a third person who arbitrates, so that once all those abstracts are looked at, they then pull full articles. So you want to somewhere be in a range of, between 10 and 30, 40 articles. And then all of those articles are read line by line, and they constitute what the review is. But what's nice about this is that these are comprehensive. You can put some restrictions on it. It's like only English speaking, it has to be a research study versus just a clinical presentation. You can include abstracts and conference proceedings or not. So there are some ways that you can kind of direct the course of this, but what you end up getting is a very wide net of kind of all the information that's out there. And I do think that these Prisma scoping reviews is now kind of the established way to do review papers on a particular topic.
Great, thank you. The next question here, do you have any instances where the discovery of past childhood trauma played a role and that impacted the veteran's openness to include the family?
That's a really important question. One of my postdocs, Rob Lane, is really going to be focusing on disclosure and the disclosing of suicidal symptoms, either disclosure to therapists or to family or to friends. And what are some of the factors that are involved in that? And I assume that mistrust and not being able to if something terrible happened to you in the past and you weren't able to share that, I'm sure that has to shape future disclosures. So I'm sure we'll be having much more information about that. Many of our veterans, especially the ones that are high risk, have histories of abuse in childhood. So I do think this is a pertinent factor and something that we need to be thinking about. But one of the areas that we want to go in the future is to kind of help facilitate these disclosures. How do you make it safe? How do you override some of these past hurts, including childhood trauma, if that is one of them, to make it so that your disclosure is done in a safe and effective way. I'm aware of peer interventions where you kind of practice the disclosure. But this is a whole new area that I think is going to have some exciting developments.
Great, thank you. I just have one comment before we move on to the next question from one of our participants. Dr. Heather Kelly is here from the House Veterans Affairs Committee. Loving all of the content, especially interested in this family LMS training. Congresswoman Underwood has legislation that will mandate VA-trained caregivers, as well as all VA staff, including VBA, all contract providers, and LMS.
Well, thank you. I have to say I love this family lethal means safety. I think it's an untapped resource. And I just want to say one thing. The reason why the New York Health Foundation funded this, and the funder told us the story, they said that for prostate exams, usually what am I talking about, prostate exams, but when you advertise directly to men, they don't get the prostate exam. When you advertise the importance of prostate exams to the spouse, they get their spouse to go get the prostate exams. And so they just said that there's such value in involving family members. It's really an untapped resource, and we have to do a better job in figuring out how to involve them and really take control or help them manage the situation more effectively and give them tools and skills. So I'm thrilled that the audience agrees with me on this, and we are excited to move this project forward and really want it out as much as possible. It's really fun to have so many people excited about this, including funders and other Governor's Challenge teams and the creators of COM themselves. They said they've been thinking that this was a really important approach. So anyway, we're hoping to launch we wanted it for the fall, but definitely by Veterans Day is our goal.
Great, fantastic. We've got about 1 minute left, so I'm just going to follow up on the comment you made there. We've gotten a lot of questions. How do you refer someone to Project Lifeforce?
Oh, okay. Email me. We will figure this out. I don't know how we can do it if we're not. We'll have to think about this because I definitely want to move in a telehealth direction. So if there are people, we'll find a way. It might require some because it's research, and I sort of have to have. There's issues about credentialing in different hospitals, but if we can get enough of interest, then we can go talk to the appropriate people. How do we make this happen?
Sounds great. We are at the top of the hour here, so we are going to wrap things up. We do still have several pending questions here that I can pass along to Dr. Goodman.
Perfect.
Or her contact information is on the screen here. I want to thank everyone for joining us today. Dr. Goodman, thank you so much for taking your time to prepare and present today. We really do appreciate it.